Hello guys, welcome back to my channel NAV Talks. In previous class, I explained some basic information about general anesthesia, but in this class, I'll explain what is general anesthesia and its importance. Before moving on to the topic, if you haven't subscribed to my channel, kindly subscribe and like the video. If you like the video, please give me thumbs up and share this to your friends also. I hope you guys enjoyed my previous class. Thank you so much to all my amazing subscribers and continue to show your love towards me so that I'll try to do good topics videos which will be easily understandable. So now we will not waste any time. Let's dive into the main topic, that is general anesthesia. Please watch entire video without skipping anything guys, please. You can see in this picture ECG attached to only in all the like OTs only three leads are attached here. Uh, but generally there are five leads, but only they'll attach three leads. That is right arm, and left lower left. Only these three leads are attached. So next is NIBP. NIBP. This all people will know this one. They'll apply BP cuff and they'll connect to the machine monitor. So they'll measure BP. That is NIBP, non-invasive blood pressure. They'll monitor. And after this, what is the normal range of BP? It is 120 by 80 mmHg. So they'll take a record, starting record of the patient. And next is ETCO2. ETCO2 means you can see this cable. This is attached between circuit and this thing airway, endotracheal tube and airway. So what this equipment will do? This will measure end tidal carbon dioxide volume. You can see ETCO2 means end tidal carbon dioxide volume. Means what it will do? It will measure oxygen sorry carbon how much carbon dioxide is eliminating from the lung, how much carbon dioxide is eliminating from the lung. So if it is more carbon dioxide is more, if the carbon dioxide is eliminating more, means there is a oxygen is going, but lung is not perfusing. Ventilation is there, but perfusion is not there. So that rise in EtCO2 means ventilation but not perfusion. If the EtCO2 is showing low, means patient is not getting enough oxygen, that is he is not ventilating properly. So it will measure how much carbon dioxide is eliminating from the lung. So you can see in this monitor, say it is showing heart rate here 117. Normal heart rate is 60 to 100 beats per minute. And you can see here SpO2, that is saturation. It should be in normal healthy patient, it should be 98 to 100 mmHg. Sorry, 100 percent. It will be in percentage, not in mmHg. It will be in percentage. So that is SpO2. Next it is EtCO2. You can see here graph. Patient is taking a normal breath and he is exhaling the carbon dioxide. This line shows he is exhaling, and he is taking normal oxygen, he is inspiring and he is leaving. So this is the EtCO2 graph. You can see it is between 32 to 42. Here it is showing 39. Sometimes it may vary in like in COPD asthma patient or someone. So that is this monitor chapter is also a different and separate topic. And here is NIBP. NIBP, you can see here 114 by 73, and the map is, that is mean arterial pressure is 87. It should be between 60 to 100 100 beat per 100 mmHg. You can see here it is 114 by 73. This is the monitoring. So this is familiar with people who is working in OT, operation theater. This monitor is very familiar to them. Next, we will move on to the procedures. Procedure. What is the procedure? So we attach monitor. Everything is done. Patient is settled down. Next, what is the next step? What they will do? They will oxygenate the patient for 2 to 3 minutes. You can see in this picture. He is holding mask like C&D technique. In a C&D technique, he is doing mass ventilation. He is giving pre-oxygenation for 2 to 3 minutes. That should be 100% oxygen should be given in pre-oxygenation period, because patient in what is the use of this one? This will reserve the oxygen concentration in the lungs, and it will eliminate the nitrogen from the body. Denitrogenation is there, and oxygen reservation is there. For that reason, we will anesthesiologist will pre-oxygenate the patient for 2 to 3 minutes. That is 100% oxygen should be given. So simultaneously with pre-oxygenation, they will the other person who is assisting anesthesiologist will give pre-medications like glycopyrrolate, midazolam, fentanyl. See, glycopyrrolate is a group of anticholinergic drug. It comes in anticholinergic group of drugs, so it will reduce secretions. So for that reason, we will give glycopyrrolate. It will reduce the secretions in the like throat secretions or something. And midazolam will reduce the anxiety of the patient. Patient anxiety will be reduced. So it will reduce the patient anxiety. To calm the patient, we will give midazolam. Next is fentanyl to reduce the pain. It will reduce the pain. Fentanyl will reduce the pain. So we will give pre-medication drugs. Glycopyrrolate, midazolam, fentanyl for as a pre-medicative drugs to reduce the secretion, to reduce the anxiety, to control the pain, to reduce the pain. So we will give these drugs as a pre-medicative drugs. Next is after pre-medication, what they'll induce the patient. They'll induce they with the help of either thiopentone or propofol or ritomidate or ketamine. Any one of these drugs they'll use, and they'll induce the patient, and these drugs will act on central nervous system, and they'll depress the central nervous system, so that patient will be in unconscious mode after giving these drugs. So that is the word we will call it as induction. They'll induce the patient. After inducing the patient, we will give in rapid sequence intubation. We will give scoline. Scoline means succinyl choline. The full form of scoline is succinyl choline. They'll use scoline. Scoline after giving scoline, patient will start fasciculating. So once fasciculating means he'll start moving like there is a moment in his um, fingers in leg or in hands. After it will last for only 1 to 1 minute only. So after giving scoline, patient will start fasciculating. After the scoline action has gone, what they'll do, they will intubate the patient. What scoline will do? Scoline will relax the laryngeal muscle. So it will relax the laryngeal muscle. So after relaxing the laryngeal muscle, it's easy to intubate the patient. So the next step is intubate the patient. Patient will be intubated. You can see in this picture, they're using laryngoscope, and they are widening through by using dominant hand, and with the help of non-dominant hand they are holding laryngoscope. They'll use this laryngoscope to guide to see the structures seen. You can see the after using laryngoscopy, we can see these structures. So epiglottis is seen. We will lift the epiglottis and we will insert the ET tube in the tracheal region. ET tube should be in tracheal region. Next, after inserting ET tube, see you can see here, after visibility of the structure, they'll insert ET tube. After inserting ET tube, patient will be settled down. Patient tube is fixed. After auscultating, after seeing that ET changes and all, they'll insert this one. They'll insert this one, and they'll fix this tube at level, like according to the patient airway entry. After checking airway entry, they'll fix this tube. After this tube fixing, they'll attach this to a circuit, and finally to the anesthesia machine, which will deliver oxygen, either nitrous or air plus sevoflurane or isoflurane mixture gases. They'll give through the anesthesia machine, through the ventilator. After this, what is the next step after intubation? Next step is to maintain the patient. We will maintain the patient by using this combination, this is, that is nitrous oxide or air. Nowadays they are not using nitrous oxide because it will cause dementia, so they are using air instead of nitrous oxide. Air plus air, either air or nitrous oxide plus atracurium or cisatracurium or vecuronium, any one of these muscle relaxant, plus isoflurane or ceoflure, any one of these inhalational agents, plus oxygen. See, before maintenance, we will give some muscle relaxant, na. This we give for laryngeal, like to relax the laryngeal muscle. After intubation, we will give any one of these muscle relaxant as a loading dose, muscle relaxant. Any one of those, any one of these drugs. Like if the patient is normal healthy 50 kg patient, vecuronium we should be give like 5 mg, 5 to 6 mg as a loading dose. But in intraoperative period, we will give 1 ml, 1 ml like that in for maintenance dose. That is maintenance dose. Loading dose is 6 mg, maintenance is 1 mg, like that we will give. And in intraoperative period, we will manage like we will maintain the patient but like N2O or air plus atra or cisatra or vecuronium plus iso or CO plus O2 will through these drugs and inhalation agents will maintain the patient. So once the operation is over, we have to bring the patient back now. There is a definition na, you saw in general anesthesia. There is a definition. So what it means, see, in general anesthesia, what they'll do, they will, after surgery, what they'll do, the patient should be brought back to normal stage with the normal vitals. So after surgery, they will they'll do thorough oral suctioning to remove the secretion from the throat, because in intraoperative period we will use a lot of anesthetic drug now, they'll increase the secretion. So we have to reduce the we have to remove the secretions by thorough oral suctioning. After that, they will start giving according to the patient condition. So we have to stop these muscle relaxant, nitrous oxide, isoflurane or some ceoflurane. We have to stop all these things before surgery, before 10 minutes or 20 minutes, based on at what time we gave these muscle relaxant. We have to stop all these. Only oxygen should be delivered. Only oxygen should be delivered. After this, patient will start moving, like start will start taking spontaneous breathing, will try to take some spontaneous breathing. So that time what we have to do, we will assess the patient, and we will start giving reversal drugs which will relax will like which will recover the patient. It's like the patient will come back to normal stage, um, uh, to from unconscious state to a conscious state after giving these drugs. So neostigmine we will give, and plus glycopyrrolate will give. So neostigmine, what it will do, it will increase the secretion and it will decrease the heart rate. So to compensate that, we will give glycopyrrolate mixture. And nowadays we have ampule like neoglate. This is full of both combination drugs, neostigmine and glycopyrrolate. But when we will give separate now, this should be each ml ampule contains zero point 0.5 mg. So we have to give 5 ampules, means 2.5 mg plus each glycopyrrolate contain 0.2 mg. So we have to give 2 ampules, means zero point 0.2 is zero point 0.4 zero point 0.4 mg plus 2.5 mg mixture we should give. How much it will be? It will be 2.9 mg. It will total, it will become 2.9 mg. 2.5 mg plus zero point 0.4 mg is 2.9 mg. So this is the when we give separate. But nowadays we have availability of neoglate, like whole combination will be available in only one ampule, or that is 5 ml ampule. So we can give this one also. This is also called as myopyrrolate also, some people will call it as myopyrrolate also. So this is the reversal thing. reversal thing. So I gave some information about this thing, procedure. But when you see in a video, or when you see in a video format, so it's very easy to understand, it's very easy to understand. So for that reason, please watch this video without missing. I'll explain while, like, with this only. I'll explain now. You start. See, first we want ET tube, injection, this thing, syringe and scope. So they are checking whether the tube is good or not. If it is not good, then we have to replace. Then they are doing pre-oxygenation here. They are doing pre-oxygenation for 2 to 3 minutes. 100% oxygen should be delivered. Then is positioning. They are widening patient's mouth. Next is laryngoscopy. They are inserting laryngoscope. After this, what they will do? They'll weave structures which are visible, and they'll lift epiglottis. After lifting that, what they'll see a structure called as trachea. So that is the part where we will insert tube. See, trachea is visible. So now they are inserting ET tube. You can see here. Step 4 is they are inserting ET tube. Once they insert the ET tube, the next step is they'll position the tube. You can see here 22. This is 21. This is 23. Middle is 22. You can see. Next is inflate the cuff. They'll inflate the cuff, so that cuff will hold the trachea. Will be in tracheal region. There is no displacement after inflating. Then they'll do bag mask ventilation. After that, they'll auscultate the patient. See, they're auscultating in 4 structures, whether the air entry is equal or not in all structure. This is not a auscultatory area. This epigastric region is not a auscultatory area. Only 4 areas will be seen. If there is any this tube displacement, only it means only one lung is ventilating. So we have to deflate that, and we have to fix it at 20 or something, 19 or 20 or 19. Then we can again auscultate, and this will be visible, and we have to fix the tube. If it is in correct position, that ETCO2 graph will also show. That graph will come like I shown in previous monitoring this thing now. So it will show like normal graph. He is breathing normally. It means it's in tracheal region. So that is the step. You saw video na. This is very useful. So next we will move to the depth of anesthesia. Depth of anesthesia means we saw in those steps now. That only depth of anesthesia means intubation, induction, maintenance, and recovery. You can see. Use pre-anesthetic medication. We used glycopyrrolate, midazolam, and fentanyl to reduce anxiety, to reduce secretion, to reduce pain. We will use pre-anesthetic drugs. After that, we will induce the patient by thiopentone or suitable alternatives like propofol, ketamine, etomidate, or like any one of these drugs will use as an inductive drug through IV. After that, in rapid sequence intubation, what they'll do, they'll use choline. It will relax the laryngeal muscle, and after elimination of muscle fasciculation, the next step is we will settle the patient. And in intraoperative period, what they'll do, they'll use either nitrous oxide or air and halogenated hydrocarbon like isoflurane or sevoflurane. Then they'll monitor and maintain with muscle relaxant like atracurium, cisatracurium, or vecuronium based on the patient condition, and they'll start monitoring. Once the surgery is over, we have to withdraw those muscle relaxant by using some withdrawal drugs like neostigmine plus glycopyrrolate. Then that period is called as recovery period. So this is here patient will be in stable condition with patient should be patient vital should be in normal condition. That is the If patient start taking so like normal spontaneous breathe and he is maintaining his saturation, that is recovery period. That time we can remove the tube and we can put him in, like we can put normal O2 mask after recovery. This is the step in general anesthesia. Next, you can see this picture here. In this picture, you can see what induction drug we used. What induction drug we used, like either thiopentone or propofol or ketamine, like which drug, induction drug we use. Now that we have to write the intubation, whether it is oral or nasal. We are intubating through oral, na? So we have to write oral size, which size we have, 7.5 for female, 8.5 for male, like that. What size we used, we have to write, and whether it is cuffed or uncuffed. Uncuffed is for pediatric, cuffed is for adults. So we have tried that here. And maintenance, like nitrous or air plus iso or co plus o2 plus muscle relaxant like atrasis cetera or vecuronium, that we have to write here. Then next is mechanical ventilation or spontaneous ventilation, we have to write here. In general anesthesia it is mechanical ventilation only. We have to write mechanical ventilation because we, it will be the patient respiratory will be dependent on anesthesia machine, so we have to write mechanical ventilation. Tidal volume, normal tidal volume will be 500 ml na, that we have to write. Frequency like 14 to 16 mm of H2O, that we have to write. Paw pressure, airway pressure we have to write. And what all drugs we give na, pre-medication, induction drug, muscle relaxant, that we should mention here. According to here, we have to write time and all, and according to that, we have to write muscle relaxant should be repeated na, after 10 20 minutes or 15 minutes, based on the based on which muscle relaxant we gave. So we have to maintain na 1 plus 1 or zero point 0.5 mg, like that we have to write here. And IV fluid, which IV fluid we are using, how many, like how much fluid is going to that patient. Fluid monitoring should be there na, otherwise fluid overloading will be there na. For that reason we have to write IV fluids. Urine we have to analysis whether urine is coming or not. That we have to monitor. Urine monitoring should be done. Temperature, if the patient is stable, temperature is okay or not. If he is febrile or febrile, that we have to mention here. Respiratory rate, that is whether from between that should be between 12 to 8, 16 or 12 to 18. Next is O2 100%, that is saturation, is whether saturation is 100% or 98%, we have to mention that. Then EtCO2, we saw graph na, EtCO2, that we have to mention here. Then if we inserted any CVP, central venous catheter, that we have to mention here. Pressure, in normal generally it's not useful, like in cardiac patient or some other patient we will use this one. These are all generally used, and we have to mention here heart rate according to time. What was the heart rate, what is the um, heart rate change, whether heart rate is changing and how much it is, we have to write, like we have to write here that recording. And blood pressure also we have to record at what time, how much was the, was his blood pressure, that also we have to write here. And which anesthesia we gave, we gave any general anesthesia or spinal anesthesia, we have to write. In general anesthesia we have to write under GM. And here we have to write any, if you want to write any extra, or whether the patient is complicated or what, we have to write here. That is general anesthesia. Next is recovery. After giving recovery drugs, what will happen? Patient will be in stable position. Na? So we have to write the vitals of the patients here in recovery. Here is the recovery line. It is cropped actually. So we have to write here vitals like blood pressure, etc. Blood pressure, oxygen, and ECG, that we have to write here. And here it will be post anesthetic advice will be there, like after surgery, after surgery patient should be NBM for some hours na? In general anesthesia patient should be NBM. After surgery NBM for 6 hours, that we have to write here. That NBM is different, like after surgery, this after surgery NBM, he should take water or some food after surgery, he should take something na, that is like after surgery after 6 hours of surgery, he can take anything, not anything, like based on the condition. Next is IV fluids, like which IV fluid is good for that patient. This is post anesthetic advice. So which IV fluid and how much IV fluid should be given, like how many ml per hour, 60 ml per hour, or what, that we should be written here. This is the anesthesia record in intraoperative and postoperative. We saw that in a preoperative evaluation, and that is like they are all in one paper only. That is, this is back side, that is in front side. Next is thank you. Thank you so much for watching. Please, if you haven't subscribed yet, please go and tell your friends to do also. Thank you for watching like a whole video without skipping. Please subscribe, and please stay tuned for the next class. And lots of love to all my amazing subscribers. Please show me your love by subscribing this channel and support me. Thank you so much, guys. Thank you. Bye, Veena. Thank you so much.